We are discussing about the drugs which are used for the treatment of peptic ulcer. In previous 3 videos we had discussed about the introduction to the peptic ulcer and classification and the different site of actions of the drugs and the pharmacology of H2 antihistamines and proton pump inhibitors. Here we will discuss the pharmacology of anticholinergics, prostaglandins and other drugs which are used for the treatment of peptic ulcer. So let's start with the anticholinergics. Mechanism of actions of anticholinergics in reducing gastric secretion is by blocking the muscarinic M1 receptor which are present in the parietal cell. So by blocking this muscarinic receptor, it will reduces the volume of gastric juice without raising its pH unless there is a food in the stomach to dilute or dilute the secreted acids. Stimulated gastric secretion is less completely inhibited by these anticholinergic drugs. Now examples of anticholinergic drugs which are used for the treatment of peptic ulcer are pyrenzepine, propendolene, oxyphenonium, and these are effective in ulcer healing, like non-selective anti-muscarinic drugs like atropine, propendolene and oxyphenonium are mainly used. And pyrenzepine is a selective M1 anticholinergics which are used for the treatment of peptic ulcer. So this is the site of action of this anti-muscarinic agent or anticholinergic agents. This antagonist will block the M1 receptors and thereby it will muscarinic receptor M3 as well as M1 receptors, thereby it will inhibit the calcium dependent pathway to activate this proton pump, so thereby it will reduces the secretion of acid. Now another drugs which are used for the treatment of peptic ulcer is prostaglandin analogs like misoprostol. This is effective orally in case of NSAID induced peptic ulcer. PGE2 and PGI2 are produced in gastric mucosa and appear to serve protective role by increasing acid secretion as well as by promoting mucus as well as bicarbonate secretion. So by using misoprostol, which is an prostaglandin analogs, this drug can be used to inhibit the acid secretion as well as to promote the mucus as well as bicarbonate secretions. Prostaglandin inhibit the gastrin release as well as it will increases the mucus blood flow and probably have ill-defined cytoprotective action when compared with other drugs. But this is contraindicated in case of pregnancy because they will contract the uterus and it may induce the laboring in case of pregnancy. And there are some adverse drug reactions like diarrhea, abdominal cramp, uterine bleeding, abortion and need for multiple daily doses. These are the different adverse drug reactions of misoprostol. So these are the different drugs which are used to decrease or inhibit the gastric acid secretion, H2 histamines, anticholinergics, proton pump inhibitors and prostaglandin. Now coming to the antacids, these are the drugs which are usually used to neutralize the gastric acid which is already secreted in the stomach. അപ്പോൾ നമുക്ക് സാധാരണ പെപ്റ്റിക് അൾസർ ഉണ്ടാവുന്ന സമയത്ത് ഹാർട്ട് ബേൺ എന്ന് പറയുന്ന പ്രോസസ്സിൽ കൂടുതൽ HCl സെക്രീഷൻ ഉണ്ടാവുന്നത് കൊണ്ടാണ് നമുക്ക് ഫീലിംഗ് വരുന്നത്. അപ്പോൾ അങ്ങനെയുള്ള കണ്ടീഷൻസിൽ ഓൾറെഡി HCl സെക്രീഷൻ കൂടുതൽ സെക്രീറ്റഡ് ആയിട്ടുണ്ടെങ്കിൽ അതിനെ ന്യൂട്രലൈസ് ചെയ്യാൻ വേണ്ടിയിട്ട് നമ്മൾ യൂസ് ചെയ്യുന്ന ഏജൻറ്റിനെയാണ് ആൻറ്റാസിഡ് അല്ലെങ്കിൽ ഗ്യാസ്ട്രിക് ആസിഡ് ന്യൂട്രലൈസേഴ്സ് എന്ന് പറയുന്നത്. So this is again classified into systemic antacids as well as non-systemic antacids. So what is antacid? These are basic substances which will neutralize the gastric acid and rises the pH above 4 of the gastric content. So peptic activity is indirectly reduced and do not decreases the acid production. It cannot use it to decrease the acid secretion for the treatment of peptic ulcer, but this is used to neutralize the already secreted acid in the stomach. അപ്പോൾ അൻറ്റാസിഡ് എന്ന് കേൾക്കുമ്പോൾ തന്നെ മനസ്സിലാക്കുക ആൻറ്റി ആസിഡ് ആണ്, ആസിഡിനെ ന്യൂട്രലൈസ് ചെയ്യാൻ വേണ്ടിയിട്ട് യൂസ് ചെയ്യുന്ന ഒരു ഏജൻ്റ് ആണ്. ഇങ്ങനെയുള്ള കണ്ടീഷനിൽ, അതായത് ഓൾറെഡി HCl സെക്രീഷൻ കൂടിയത് കൊണ്ടുണ്ടാകുന്ന ഹാർട്ട് ബേണിനെ ആ സിംറ്റംസിനെ മാത്രം റിലീഫ് ചെയ്യാൻ വേണ്ടിയിട്ട് മാത്രം യൂസ് ചെയ്യുന്നതാണ്. വി കനോട്ട് യൂസ് ഫോർ ട്രീറ്റിംഗ് പെപ്റ്റിക് അൾസർ, വി ക്യാൻ യൂസ് ഫോർ റിലീവിംഗ് ദ സിംറ്റംസ്. And what are the different ideal properties of an antacid? It should be insoluble, it should be non-adsorbable, it should not liberate carbon dioxide, it should not affect the acid-base balance of the body. So that is the antacid. Now antacids may be of systemic, which are water soluble like sodium bicarbonate and sodium citrate, and non-systemic, insoluble and purely absorbed like magnesium hydroxide, aluminum hydroxide, magnesium trisilicate, and calcium carbonate and megaltrate. Let's discuss one by one. First one is bicarbonate. This is a water soluble and which will act instantaneously with a short duration of action. This is a potent neutralizer with acid neutralizing capacity. 1 gram will be neutralize 12 milliequivalents of HCl and rises pH above 7. But there are some demerits, like these are absorbed systemically, thereby large doses may induce alkalosis and it may produce carbon dioxide in the stomach, so it may cause distension, discomfort, bleaching, risk of ulcer perforations. Acid rebound occur, but usually for short lasting. It can increases the sodium loads and may worsen the edema as well as congestive heart failure. And this is mainly used to treat the heartburn and to provide quick symptomatic relief, and also it is used to alkalinize the urine to treat the acidosis. So this is the systemic antacid like sodium bicarbonate. Now coming to non-systemic antacid, these are insoluble and purely absorbed basic compounds which are used to neutralize the gastric acid, and usually it will react in the stomach to form corresponding chloride salt. This chloride salt again react with the intestinal bicarbonate, so that the bicarbonate do not spare for the absorption. There will not produce no acid there will not be any acid base disturbances. So that is the non-systemic antacid. Magnesium hydroxide, this is have low water solubility, and its aqueous solution as milk of magnesia have low concentration of hydroxyl ion and thus low alkalinity. It will react with the HCl promptly and it is efficacious antacid. 1 gram will be neutralized 30 milliequivalents of HCl, and rebound acidity is mild and brief when compared with the sodium bicarbonate that is used as a systemic antacid. Now this is example for non-systemic antacid, magnesium hydroxide. Now coming to another non-systemic antacid, that is the magnesium trisilicate, which have low solubility and low reactivity. 1 gram can react only 10 milliequivalents of acid, but in clinical use only 1 milliequivalent is neutralized. Of about 5% of the administered magnesium is absorbed systemically, may cause problem if renal function is inadequate. All the magnesium salt have laxative action by generating osmotically active magnesium chloride in the stomach, and through magnesium ion induced cholecystokinin release. Soluble magnesium salt are used as an osmotic purgative also. Now another non-systemic antacid is aluminum hydroxide. This is a bland, weak and slowly reacting antacid. Aluminum ions will relax smooth muscle and delay gastric emptying. It can cause constipation due to the smooth muscle relaxation as well as mucosal astringent action. Aluminum hydroxide bind with the phosphate in the intestine and it will prevent its absorption of phosphate, and it can lead to hypophosphatemia, and which may cause osteomalacia, and it is used therapeutically in case of hyperphosphatemia as well as phosphate stones. Now another non-systemic antacid is megaltrate. It is an hydrated complex of hydroxy magnesium aluminate. that initially react rapidly with acid and it will release aluminum hydroxide, and the freshly released aluminum hydroxide is then is in the unpolymerized form are more reactive. So this will react with next group of HCl to neutralize the hydrochloric acid. Even though megaldrate cannot be equated to physical mixture of magnesium as well as aluminum hydroxide, it is a good antacid with a prompt and sustained neutralizing action. So that is a megaldrate. But as we mentioned before, in case of magnesium hydroxide, it have a rapid onset of action, but it may cause diarrhea. And in case of aluminum hydroxide, it have a low onset of action and it may cause constipation. So by combining these two, aluminum hydroxide as well as magnesium hydroxide, the side effect of one antacid can be potentially masked by one another. So usually the antacids are combined by magnesium hydroxide and aluminum hydroxide to counterbalance the side effects of diarrhea and constipation, so that the combined antacid is more effective than the individual antacids which have some side effects. In antacid, simethicone and dimethicones are used as an anti-foaming agent along with the antacids. Now, important drug interactions of antacids are, it will raises the gastric pH, and also it may form complexes with the non-absorbable antacid, will decreases the absorption of many drugs like tetracycline, iron salt, fluoroquinolone, ketoconazole, H2 blocker, diazepam, phenothiazine, indomethacin, phenytoin, isoniazid, ethambutol and nitrofurantoin. Efficacy of nitrofurantoin is also reduced by alkalinizing the urine. So these are the some important drug interaction. Now, antacidന്റെ പ്രത്യേകത എന്ന് പറയുന്നത് ആസിഡിനെ ന്യൂട്രലൈസ് ചെയ്തിട്ട് ആസിഡിക് പി എച്ചിനെ ബേസിക് പി എച്ച് അല്ലെങ്കിൽ ന്യൂട്രൽ പി എച്ചിലോട്ട് എത്തിക്കുക എന്നുള്ളതാണ്. അപ്പോൾ പല ഡ്രഗ്സുകളും അസിഡിക് പി എച്ചിൽ കൂടുതൽ അബ്സോർപ്ഷൻ കാണിക്കുന്ന ഡ്രഗ്സുകളാണ്. അപ്പോൾ അങ്ങനെയുള്ള ഡ്രഗ്സുകളുടെ അബ്സോർപ്ഷൻ കുറയുക എന്നുള്ളതാണ് മെയിനായിട്ട് ഒരു ഡ്രഗ് ഇൻറ്ററാക്ഷൻ. ഈ അൻറ്റാസിഡുകൾ H2 ബ്ലോക്കറിൻ്റെ കൂടെ കഴിക്കുമ്പോൾ അല്ലെങ്കിൽ കീറ്റോകൊണസോളിൻ്റെ കൂടെ കഴിക്കുന്ന സമയത്തൊക്കെയുള്ള പ്രോബ്ലം എന്ന് പറയുന്നത് ഒന്നുമില്ലെങ്കിൽ അവിടെ ഒരു ഗ്യാസ്ട്രിക് പി എച്ച് റൈസിങ് ഉണ്ടാവുന്നുണ്ട്, അതല്ലെങ്കിൽ ഒരു കോംപ്ലക്സ് ഫോർമേഷൻ ഉണ്ടാവുന്നുണ്ട്. ഓക്കെ, അതുപോലെ നൈട്രോഫ്യൂറഡൈൻ്റെ കേസിൽ ആൽക്കലനൈസ് ചെയ്യുന്നത് കാരണം അതിൻ്റെ നൈട്രോഫ്യൂറഡൈസിൻ്റെ എഫക്റ്റ് റിഡ്യൂസ് ചെയ്യുക എന്നുള്ളത് വേറൊരു ഡ്രഗ് ഇൻറ്ററാക്ഷനാണ്. ഓക്കെ, നൗ വാട്ട് ആർ ദ യൂസസ് ഫോർ antacid? First of all, we have to understand that antacids are used to neutralize the acid which is already secreted, not to reduce the acid secretion. Okay, അതുകൊണ്ട് തന്നെ ഇത് പെപ്റ്റിക് അൾസർ ഹീലിങ്ങിന് കൂടുതലായിട്ട് നമ്മൾ യൂസ് ചെയ്യുന്നില്ല. പിന്നെ എന്തിനാണ് നമ്മൾ യൂസ് ചെയ്യുന്നത്? ഇന്റർകറന്റ് പെയിൻ റിലീഫ് ആസ് വെൽ ആസ് അസിഡിറ്റി ഉണ്ടാവുന്ന സമയത്തും പെയിൻ ഉണ്ടാവുന്ന സമയത്തും ഹാർട്ട് ബേൺ ഫീൽ ചെയ്യുന്ന സമയത്ത് അതിനെ ന്യൂട്രലൈസ് ചെയ്യാൻ വേണ്ടി മാത്രമാണ് നമ്മൾ ആൻറ്റാസിഡ് യൂസ് ചെയ്യുന്നത്. ഓക്കെ, സോ ഇറ്റ് ഈസ് നോ ലോങ്ങർ യൂസ്ഡ് ഫോർ ഹീലിംഗ് ഓഫ് പെപ്റ്റിക് അൾസർ, used only for the intercurrent pain relief as well as acidity, and used for non-ulcer dyspepsia and minor episodes of head burn. Antacid afford faster symptom relief than the drug which inhibit the acid secretion but do not provide the sustained benefits. So that is the uses of antacids. In another video, we will discuss about the sucralfate ulcer protective agents like sucralfate and anti-H. pylori drugs.